Imagine a chronic condition that affects roughly 10% of all reproductive-aged individuals.
Which is a massive number of people.
Right. Massive.
Yeah.
And it causes immense, sometimes completely debilitating pain. It severely impacts fertility. It costs society over $27,000 per patient annually in direct and indirect costs.
Yeah.
And yet, despite all of those staggering numbers, it takes an average of 7 to 12 years to actually get an accurate diagnosis.
It's, honestly, it is a profound failure of modern medicine.
Mm-hmm.
And it is a reality that millions of people are living with literally every single day.
Yeah. Today, we are pulling from a really massive, incredibly detailed 2025 medical review. This was published in Obstetrics and Gynecology by Dr. Erin T. Carey and her colleagues. Huh. And the mission for this deep dive is to, completely reframe how you understand endometriosis.
Because if you think it's just, quote unquote, bad cramps.
Right, which so many people do.
Exactly. If that's what you think, you are missing the entire picture.
Completely. So we are going to look at what this disease actually is, which is a full-body, systemic, estrogen-dependent inflammatory disorder. We'll look at why it takes over a decade to identify and the incredibly complex reality of treating it. Okay, let's unpack this.
So most of our listeners probably know the basic definition of endometriosis, right? It's tissue similar to the lining of the uterus growing where it shouldn't.
Right, outside the uterus.
Exactly. But to understand that shocking diagnostic delay, that 7 to 12 years, we really have to dismantle the myth that it is just a localized reproductive issue. Dr. Carey's paper highlights how this tissue literally functions as a rogue endocrine gland.
A rogue endocrine gland. Wow.
Yeah. And the stats are brutal. 60% of patients experience chronic pelvic pain, 80% deal with dysmenorrhea, so severe period pain, and up to 50% face subfertility or even infertility.
And what really struck me reading this is how far it reaches beyond the pelvis. This disease alters the body's entire hormonal metabolism.
It does.
It affects non-reproductive organs and drastically increases a patient's susceptibility to things like autoimmune disorders and even cardiovascular disease.
Exactly. And when we look at the localized pathophysiology, so how the disease actually functions at the cellular level, we see just how insidious it really is. Because for decades, the medical community just operated on this assumption that these ectopic lesions were just, misplaced uterine lining.
Like it just took a wrong turn.
Right. But they aren't. They are distinct entities. They have their own entirely separate physiological behaviors.
And the aromatase P450 activity is like a perfect example of that.
Yes.
Because aromatase is essentially an enzyme that synthesizes estrogen, right?
Magic.
And Dr. Carey's team found that these lesions have incredibly high levels of this enzyme. So they are literally manufacturing their own localized estrogen to drive their own growth.
Which is terrifying when you think about it.
It is. It's like a rogue invasive weed in your garden. It doesn't just grow where it shouldn't. It actually manufactures its own specialized fertilizer to make sure it survives.
That's a great way to put it.
And while it's doing that, it builds a fence to keep the immune system's weed whackers out.
What's fascinating here is how effectively it constructs that fence. These lesions induce a localized inflammatory response by releasing these signaling proteins, things like interleukin-1 beta, IL-6, and tumor necrosis factor alpha.
Okay, that's a lot of science words.
I know. You don't need to memorize the chemical names.
Okay.
But you do need to know what they do. They basically act as scrambled communication signals that paralyze the body's peritoneal macrophages and natural killer cells.
So the very immune cells that should be sweeping through the body and clearing out this rogue tissue are essentially told to stand down.
Precisely. They are totally neutralized. The tissue disrupts the body's inflammasome pathway and elevates local prostaglandins. And this creates a perpetual self-sustaining cycle.
Right.
The local estrogen production drives the growth of the lesion, and then the local inflammation paralyzes the immune response that would normally stop it.
Wow.
This is exactly why standard hormonal regulation, which just relies on the body's normal feedback loops, is incredibly difficult to manage. The disease has built its own independent ecosystem.
Okay, so if these cells are busy building their own, immune-proof fortresses inside the pelvis, how are they getting outside the uterus to begin with?
Honestly, that is the ultimate question in endometriosis research right now. The data outlines 3 distinct phenotypes: superficial peritoneal endometriosis, ovarian endometriomas, and deep endometriosis.
And deep endometriosis is categorized by tissue that invades, what, more than 5 millimeters into surrounding
Yeah,
structures?
exactly, over 5 millimeters. And the medical community is currently really debating whether these are progressive stages of a single disease or...
Or if they're just entirely separate conditions that happen to share a name,
Right.
which is wild. And the theories regarding how it all starts are just wild, too. The classic one, the one we always hear about, is Sampson's theory of retrograde menstruation,
Right.
where the idea is that menstrual blood flows backward through the fallopian tubes during a period, and it spills into the pelvic cavity where the cells just, implant and grow.
Yeah. And that has been the dominant theory for nearly a century. But modern research immediately complicates it. I mean, retrograde menstruation might explain some superficial surface lesions, sure.
Yep.
But it absolutely cannot account for the deep tissue invasion we see in other phenotypes. Like, for instance, deep endometriosis often involves an abnormal overgrowth of muscle tissue deep behind the abdominal cavity.
Wait.
And retrograde blood simply couldn't cause that on its own.
Wait, let me challenge that retrograde theory even a step further because the anatomy just doesn't add up to me.
Go for it.
We know that rare extrapelvic endometriosis can show up in the lung pleura, the pericardium around the heart, and even the brain.
Yes, it can.
So if this disease is really just blood flowing backward into the pelvic bowl, how on earth is it reaching a patient's lungs or brain?
Well, this raises an important question, and it is exactly why researchers are looking far beyond Sampson's theory today. Because to explain those extrapelvic locations, we have to look at lymphatic or hematogenous spread.
So wait, if it's traveling through the lymphatic system or the bloodstream,
Yeah.
that fundamentally shifts endometriosis from a period problem to something behaving almost like a benign cancer, just hitching a ride on the body's highway system.
That is a very accurate way to conceptualize it. And honestly, it doesn't stop there. There's also the theory of endometrial stem cell recruitment.
Which is what exactly?
That's where circulating progenitor cells, basically blank slate cells in the bloodstream, they get trapped outside the uterus and just differentiate into endometriosis.
Wow.
Furthermore, we have the Mullerian rest induction theory.
Okay, let's unpack that one because I know that dives all the way back to fetal development.
Right. So during fetal development in the womb, the reproductive tract forms along these very specific migratory pathways. And the Mullerian rest theory suggests that primitive embryonic cells accidentally get dropped or misplaced along that pathway.
While the fetus is still developing.
Exactly. They lie dormant for decades. And then, usually around puberty when estrogen production ramps up, they activate and develop into endometriosis.
Which means someone could literally be born with the biological groundwork for this disease already laid out in their body.
Exactly. What the experts are realizing is that this is a polygenic, multifactorial disease. We are likely looking at several different mechanisms of origin, all currently grouped under the umbrella of endometriosis.
Man, when you have a disease that can originate in 3 different ways, travel through the bloodstream, and embed itself anywhere from the pelvic floor to the lung pleura,
Yeah.
you're inevitably going to have a profoundly complex pain response, which I guess explains that decade-long wait for a diagnosis.
Oh, absolutely. The pain pathway is perhaps the most misunderstood aspect of the entire disorder. Because one of the most counterintuitive facts we see in the clinical data is that pain severity does not correlate with disease severity.
Wait, so a patient with just a few, millimeter-sized superficial spots could be completely bedridden, while someone with deep invasive tissue overgrowth might not even know they have it.
Yes, that happens all the time. And it all comes down to neurology. We mentioned earlier that the lesions cause chronic inflammation, and they draw in those macrophages.
Right, the paralyzed immune cells.
Right. Well, those macrophages produce a specific neurotrophic factor called IGF-1, or insulin-like growth factor 1. And this factor physically interacts with the local nerve endings, hypersensitizing them.
Okay.
So the nerves adjacent to the lesions become hyperreactive. And this leads to 2 critical phenomena, viscero and viscerosomatic sensitization.
Okay, to visualize viscerosensitization, I like to imagine a cross-wired electrical system in a house.
That's a good way to look at it.
Right, so you walk into your kitchen, you flip the light switch, but because the wires are crossed deep in the walls, it doesn't turn on the light, it accidentally triggers the smoke alarm in the bedroom.
Exactly.
So a stimulus or an inflammation from one internal organ, like the uterus, triggers a pain response in a completely adjacent organ, like the bladder or the bowel.
And viscerosomatic sensitization takes that even a step further. That is when an inflamed internal organ triggers a reaction in the muscles and skin.
Oh, wow.
Yeah. So, for example, severe inflammation on the bowel might cause the entire pelvic floor muscle group to just lock up in a chronic painful spasm.
Which creates this totally diffuse, chaotic map of pain that baffles both the patient and the doctor.
Right.
I mean, when a patient presents with chronic bladder pain and a tight pelvic floor, the doctor naturally investigates the bladder, or they recommend muscle relaxers. They don't immediately think to look for an estrogen-producing lesion hiding behind the uterus.
No, they don't. And because the pain is referred and doesn't match the visible severity on a standard exam, patients are routinely dismissed. I mean, historically, the absolute gold standard for diagnosis was surgical staging.
Like putting a patient under anesthesia and performing a laparoscopy to visually confirm the tissue.
Right, which is a huge hurdle.
But advanced imaging is finally changing that landscape, right?
It is, but it requires extreme expertise. Standard transvaginal ultrasounds often miss endometriosis completely because the tissue just blends in. You need advanced MRI protocols or a truly expert-level ultrasonographer. For example, specialists now look for the uterine sliding sign.
Yeah, I found the mechanics of this fascinating in the paper. It's just a simple 5-minute maneuver during a transvaginal ultrasound. The technician gently applies pressure to the cervix to see if the anterior rectum slides freely across the back of the vagina and uterus.
Right.
And if it doesn't slide if it appears stuck, it strongly indicates deep endometriosis and severe adhesions binding the internal organs together like glue.
It is a brilliant, non-invasive diagnostic tool. But you have to specifically know to look for it. And we also have to address the commercial diagnostic market here.
Oh, yeah. The blood tests.
Yes, because despite a lot of heavy marketing for blood and saliva tests, the data clearly states that biomarkers are not yet reliable for diagnosis.
They just aren't there yet.
No. To safely replace surgery, a biomarker needs 94% sensitivity and 79% specificity. And currently, nothing on the market consistently hits those rigorous numbers.
So someone spends 10 years navigating a cross-wired nervous system. They finally get an expert who spots the warning signs on an ultrasound, and they get their diagnosis. What exactly is the medical field offering them at that point? Because stepping into the treatment landscape isn't exactly finding a silver bullet.
No, it's not. It is a precarious balancing act of symptom management rather than an outright cure. Medical management primarily focuses on hormonal suppression. The first-line treatments are always combined hormonal contraceptives and progestins.
With the goal being just to suppress ovulation and reduce the estrogen that drives the inflammation.
Exactly.
But as Dr. Carey's review points out, approximately 30% of patients report absolutely no pain improvement with those contraceptives.
Right.
And that links right back to what we discussed earlier. The lesions have progesterone resistance. They simply don't respond to the hormonal stop signs the way normal uterine tissue does. So what happens when that first-line defense fails?
Doctors move to heavier medical interventions, specifically GnRH agonists or antagonists.
Right. To visualize this, it's like starving a house fire of oxygen. It puts out the flames of the lesions, but it freezes the rest of the house by plunging the body into early, chemically induced menopause.
That is the very apt analogy. It starves the lesions of estrogen, but it triggers intense menopausal symptoms. We're talking hot flashes, mood changes, and severe bone density loss.
Which sounds awful.
It's very tough on the body. Patients often require add-back hormones, which is a low controlled dose of estrogen or progestin, just to protect their skeletal structure while on the medication. There are also aromatase inhibitors, which directly target that local estrogen factory inside the lesion.
But those come with significant systemic side effects as well, right?
Yes, they do, which naturally pushes a lot of patients toward surgical intervention. But even surgery is deeply nuanced. The data compares ablation, which is essentially burning the surface of the lesions.
Just skimming the top.
Right, versus excision, which is cutting them out entirely by the root. And excision generally has much better long-term outcomes for pain relief. But if a patient has an ovarian endometrioma, which is a cyst actually on or inside the ovary surgery, it becomes incredibly fraught.
Because the ovaries are so small and delicate, you can't just pluck a cyst off the surface. You have to peel the cyst wall away from the ovarian cortex.
Exactly.
And peeling that away strips the surrounding healthy ovarian tissue.
Right. That healthy cortex houses the primordial follicles. So losing that tissue directly lowers anti-Mullerian hormone levels, which is the primary marker for ovarian reserve.
Wow.
So the surgery reduces the patient's pain, but it directly damages their future fertility. It really forces patients to make impossible, life-altering choices between living with debilitating pain or sacrificing their reproductive goals.
And for patients who have finished building their families or who just want the pain to stop at any cost, the conversation almost always turns to hysterectomy and bilateral oophorectomy, so the total removal of the uterus and both ovaries.
Yes.
But wait, let me get this straight. You can undergo a major surgery to remove your entire reproductive system, plunging your body into surgical menopause.
Right.
And the data shows the patient might still have persistent endometriosis pain.
If we connect this back to everything we've unpacked so far, it makes a grim kind of sense. Remember, the disease is defined by tissue outside the uterus.
Oh.
If those ectopic lesions have been left behind in the pelvis or on the bowel or near the diaphragm, and we know they have the aromatase enzyme to manufacture their own estrogen,
then removing the ovaries doesn't magically erase the lesions that are already elsewhere.
Exactly.
And it doesn't reverse the nervous system sensitization either. The kitchen switch is still cross-wired to the smoke alarm.
Exactly. The neural pathways have been altered by years of chronic inflammation. Now, hysterectomy can absolutely lower reoperation rates, and it is highly effective if the patient also has adenomyosis.
Which is when the tissue invades the muscle wall of the uterus itself, right?
Yes. But researchers stress it is not a cure for endometriosis. Furthermore, removing a patient's ovaries before the age of 45 carries significant documented risks for cardiovascular disease, metabolic syndrome, and osteoporosis.
Wow.
This is why treatment cannot be one size fits all. It must be fiercely customized to the patient's immediate goals.
The difficulty of navigating this disease is compounded by some stark realities regarding long-term health risks and, honestly, systemic healthcare disparities. Because this is a systemic disease, we really have to look beyond the pelvis.
We do, and we must address the link between endometriosis and cancer.
Which is a scary word for people to hear.
It is. Now, endometriosis itself is a benign condition. However, the chronic inflammation causes immense cellular stress, which can lead to somatic mutations. So, actual changes in the DNA of the lesions over time.
Okay.
Because of this, patients with endometriosis have a 4.2-fold greater likelihood of developing ovarian cancer, specifically clear cell and endometrioid carcinomas.
And if they have the deep endometriosis phenotype, that risk jumps to a staggering 9.66-fold increase.
It is a massive statistical jump. But what is truly alarming is that despite this known risk, the medical community currently has no established screening guidelines for ovarian cancer in patients with a history of endometriosis.
That is just unacceptable.
It is a major gap in care.
And when we look at who gets diagnosed and how they are treated, the demographic disparities are glaring too. Dr. Carey's review cites a comprehensive meta-analysis showing that Black women are diagnosed with endometriosis significantly less often than white women.
Right.
Asian women are diagnosed more often, and Hispanic women are diagnosed at similar rates.
But the authors are very careful to point out the context here. There is no reliable data showing any actual biological difference in the incidence of the disease across races.
So it's not a biological difference?
No. The differences in diagnosis rates are driven by clinician bias, varying access to specialized surgical care, and a historic dismissal of pain in minority populations.
The data also notes a deeply concerning statistic regarding surgical intervention. Black women are 3 times more likely to undergo an oophorectomy, the removal of an ovary in their 20s compared to white women.
Right.
It really highlights a massive disparity in how conservative fertility-sparing care is offered and accessed.
And the medical system also has significant blind spots when it comes to gender-diverse populations. The research notes that transgender men using testosterone can still have a high prevalence of active endometriosis.
Really? Even on testosterone?
Yes, because the tissue can sometimes actually convert the testosterone into estrogen, sustaining the disease.
That is wild. So what does this all mean for you, the listener, especially if you or someone you love is navigating this incredibly frustrating cross-wired system right now, fighting for a diagnosis or just trying to weigh impossible treatment options?
It means your struggle is entirely validated by the science. This is a profound, complex, systemic issue. And the data notes that since 1990, only 3 new drugs have been approved specifically for endometriosis.
Since 1990?
Right. Compare that to over 100 new drugs approved for cancer in the same time frame.
Wow.
The innovation simply hasn't matched the scale of the suffering. And because of this, patients absolutely must act as their own advocates.
And the research points toward the future of care being centralized in centers of excellence, right?
Yes. Relying solely on a standard 15-minute gynecology visit is almost always insufficient for a disease this complex. The future really relies on multidisciplinary centers.
So a team approach.
Exactly. A patient needs access to an excision specialist who focuses entirely on endometriosis. They need a pelvic floor physical therapist to untangle the viscerosomatic pain, a colorectal surgeon if the bowel is involved, mental health professionals to help navigate the psychological toll of chronic pain, and specialized radiologists who actually know how to execute that uterine sliding sign.
Because currently, only 55% of patients report satisfaction with their medical support.
Which is too low. Moving to a patient-centered, multidisciplinary model is really the only way to change that.
We are also seeing glimmers of hope in technology, though. Researchers are developing AI and machine learning tools to help predict and diagnose the disease based on patient-reported symptom clusters, essentially bypassing that initial clinician bias.
That's a huge step.
Yeah. And telehealth is expanding access, allowing geographically remote patients to actually consult with these rare centers of excellence.
The landscape is shifting, but it really demands that the medical system look past its own outdated theories and start treating the whole patient.
Absolutely. So to quickly recap this massive journey, endometriosis is not just a bad period. It is a systemic, estrogen-manufacturing, nerve-altering disease.
It behaves like a self-fertilizing weed that actively evades the immune system.
Yes, crossing the body's electrical wires and causing debilitating pain that doesn't always match what a surgeon sees on a screen. It demands highly nuanced, patient-specific care.
And it demands that we keep asking entirely new questions about where it comes from, how it operates, and how we can finally stop it.
Which brings us to a final lingering thought directly from Dr. Carey's review. We talked about retrograde menstruation, stem cells, and embryonic genetics, but the research also points to the microbiome.
Which is fascinating.
It is. It notes that the gut microbiome might heavily influence the immune-mediated chronic inflammation of endometriosis. Furthermore, certain bacteria in the body can actually metabolize and produce estrogen, and bacterial contamination might actively trigger the disease process.
Wow.
So I want you to ponder this. As we look at this systemic, seemingly incurable reproductive disorder, could the future of treating endometriosis actually lie in mapping and altering the bacteria in our digestive tracts?
It completely changes the paradigm of how we view reproductive health.
It really does. Keep questioning what you were told, keep advocating for yourselves, and keep exploring.